Catalina Alvarez. I'm a pediatric nephrologist from Mexico, and currently I'm a kidney transplant fellow and PhD student at the Hospital for Sick Children and the University of Toronto. It is for me an honor to introduce Dr. Maria Ferris. She will be giving the second part of this lecture. She is the medical director of the UNC Children's Hospital Transition Program at the University of North Carolina, and it is a privilege to me to share this presentation with the leader on the field of transition. Today, we will be talking about this very important topic of transitioning adolescents and young adults from the pediatric to the adult healthcare. We have nothing to disclose. At the end of this talk, we hope that the audience get a picture of the long-term impact of the pediatric onset of chronic and end-stage kidney disease, understand the transition process from the pediatric to adult healthcare, and to share some of the experiences and evidence so far on healthcare transition preparation. On the following 30 minutes, we will review the impact of chronic and end-stage kidney disease with pediatric onset among the different biological and psychosocial spheres. We also will review how is the healthcare preparation and self-management built in a multidisciplinary fashion. So let's start with CKD and end-stage kidney disease with a pediatric onset. What does that mean for the patients and the caregivers? And what are the consequences in the adult life? Despite it is well known that CKD and end-stage kidney disease is less incident and prevalent in pediatric population, it still represents a burden for health in several countries. There are not too many multinational registries of CKD and end-stage kidney disease in pediatric population. We definitely need more registries around the globe. In this graph from Waradis publication, showing the incidence on the left and prevalence on the right, it is apparent how these may vary across countries. This graph showed the highest incidence in the US, New Zealand, and Austria, with about 14 cases per million of population, and the highest prevalence in Italy, Finland, and again, the US, according to the US RDS from 2003. Worthy to mention that there could be lack of reporting from the countries with less infrastructure for a registry. The etiology of CKD and end-stage kidney disease with pediatric onset is differently from adults. In these two graphs with almost a decade of difference, we can see how in younger kids from infants to preschooler age, the main cause of kidney disease are the congenital abnormalities of the kidney and urinary tract, while in adolescents, primary and secondary glomerulopathies are some of the main causes. These expose the pediatric population to multiple surgical events in the cause of acute and to different immune therapies with acute events in the case of glomerulopathies, contrasting with the etiologies in adults. But the fact that there are evident differences on the disease and treatments received between children and adults with CKD and end-stage kidney disease does not mean that there won't be an impact in their adult life. Luckily, technology and science has shown their advantages in prolonging the life of our children, but this carries with the late presentation of complications secondary to its burden in a stage of life where growth and development are key for their future. We can see how each of the aspects in the left side of this cartoon impact on each of the aspects in adult life. Because CKD is a lifetime disease, even after transplant in our patients are still CKD patients. On the interest of time, I will briefly mention some of the aspects of CKD and stage kidney disease burden during childhood that carry consequences in the adult life. A very relevant complication is the cardiovascular disease. And we can see how, despite the traditional risk of cardiovascular disease are lower during childhood, the unique burden of chronic and end-stage kidney disease add on the traditional risk across the adolescents and young adults. In this recent publication from 2020, in over 80,000 children and young adults, 40% of all deaths were cardiovascular-related causes. In the left panel, we see how across eras, the cardiovascular mortality risk decreased, but remains higher in young adults when comparing with children, And in the right panel, we see how myocardial infarction was higher among children in a subgroup analysis. But how about growth? Growth represents a special challenge in children with CKD. While the disease itself impaired the kids to achieve their target height, failing to accommodate all the modifiable factors leads to short stature. Short stature has shown to impact in self-esteem, getting a partner in life, getting a job, and overall a poorer quality of life during adulthood. In this Piccolo Mondo cross-sectional study from the Mondo database at the Renal Research Institute, we showed how achieving the expected values for a good mineral and bone health in children and adolescents on hemodialysis treatment vary widely across the world regions. The right side is showing the target for phosphorus levels according age. The green shaded area shows the levels within the target. We can see how North America showed a large number of patients out of range. In contrast, in the left panel, we can see how achieving a normal height was harder for Latin America. These can be related to growth hormone access. A big burden from the dysregulation of the hypothalamic pituitary axis is seen in CKD end-stage kidney disease pediatric onset population. These dysregulations can lead to, among other things, poor testicular growth and testosterone synthesis in males, and defective follicle luteinization, prolonged amenorrhea, and delayed or poor sexual characters development in females. Brain maturation is also affected. In this time-lapse MRI, we can see the different areas of gray matter growth in a no CKD normal brain. Worthy to mention, the frontal lobe achieved full gray matter growth after 20 years of age. These especially need to be considered when we think about the strategies for transition. In contrast, in dysfunctional MRI of a CKD patient, it is evident in the right side of the image how the executive function and high-level cognitive tasks are poorly achieved in CKD patients. With all this said, how do our pediatric patients see their own life with chronic and end-stage kidney disease? What's their perspective? In this study assessing QALYs across different CKD stages in children and adolescents in the HUI-3 scale, Francis et al. Found that 77 reported a deficit in their quality of life, showing the worst scale rates in the dialysis group. Finally, touching briefly on the psychological aspects such as anxiety and a very relevant area for prognosis such as adherence, children and adolescents with CKD and end-stage kidney disease showed in this study on the left side that pediatric patients on hemodialysis experience more anxiety. And among the hemodialysis group, adolescents showed a significantly higher anxiety state comparing to other groups. Adherence remained to be a strong marker for poor prognosis. The advanced the CKD stage, the more medications needed. In this study by Dr. Blythe Hansen from the CKID cohort, they concluded that the major risk for non-adherence was dosing frequency and vintage of CKD. Now, I'll let you with Dr. Ferris talk to you about transition.
Thank you, Ana Catalina, for the wonderful presentation you gave. And it puts in perspective who we are dealing with. Now, my part of the conversation is to talk to you about healthcare transition preparation and self-management. I wanted to show a picture of Selena Gomez, who is a young adult woman who recently underwent kidney transplantation. And she's fortunate because one of her fans donated a kidney to her. And what a fantastic opportunity for these young women. But, chronic kidney disease affects anyone, as you know. The healthcare transition is a process that involves adolescents, emerging adults, their parents, and providers. But the question is, how do we take them from this age group to this age group successfully? I want to show this picture to you because this is an adult focused nephrologist, and I am handing out our patient whom I've cared for several years. The purpose of this picture is to show you that for the patient's interest, it is better for us to have a smooth transfer, introducing them to the adult nephrologist and saying, here's our patient. We've taken care of this patient for many years. I know you'll take care of him just as well as I did. And it assures the family and the patient. Granted, not always this is possible, but when feasible, please, pediatric-focused providers, make sure that you can do a handoff like this, and it's a big graduation celebration. What happens if we don't prepare the patients? Unprepared patients, when they transfer to adult-focused, have poor outcomes. These are studies done in several parts of the world. And as you can see, if patients go to the adult-focused services unprepared, they have poor outcomes such as transplant rejection, death or graft loss, a higher hemoglobin A1C, and arthritis. I'm showing this because the poor outcomes not only happen in CKD, but in patients with all health conditions. We heard from Dr. Ana Catalina Alvarez that the pediatric population is very different from the adult population because we have patients who have been diagnosed even prenatally as having congenital anomalies of the kidney and urinary tract versus those patients who were diagnosed in the adolescent years. I want to postulate to you that these families, the families of patients who were diagnosed at an earlier age, are different families than patients who were diagnosed at an older age. So in our work, we are trying to assess if there's a difference in healthcare transition preparation if the patients were diagnosed in utero, early childhood, in pre-adolescence, or in the adolescent years. And what happens if we don't prepare our patients? I took the opportunity to query adult nephrologists at one of our regional conferences, the 25th GDCN conference, and we queried adult nephrologists that were in 35 practices. And I asked them, tell me about your patient population. Tell me about the graduates of our pediatric onset, of our pediatric populations. These providers share with us that in their whole universe of patients, our graduates are only 2% of their patient population. They seem to be less knowledgeable about their diagnosis and treatment compared to adult onset patients. 45% of these graduates were considered non-adherent, and they were considered the healthiest. As you heard from Dr. Alvarez, they're really not the healthiest. They have great problems with cardiovascular disease, so they're not so healthy. When it comes to non-adherence, I'm going to propose to you that these are not very different from your adult patients. And most importantly, the problems the adult nephrologist mentioned to us is that our patients come with parents. And I want to postulate to you that having a parent with you, actually, it's a good thing because it can give you a better opportunity to share the load. But we just have to learn to manage these parents and have them not be such helicopter parents, preventing the adolescents to learn about self-management of their disease. I'm going to now share some of our program and our tools. Over the last 14 years or so, we have developed tools to measure healthcare transition and to help with healthcare transition preparation. And we've also developed interventions to help with the healthcare transition preparation. Initially, when we started in this field, I had the idea that patients who were 12 years of age were different, certainly in maturity level, from the 20-year-old patients. But I also had the concept of what 20-year-olds could handle compared to 12 years old patients. In this longitudinal study, which is probably the only one in the world so far, of observations of greater than 10 years, we've actually characterized the healthcare transition preparation tools, the healthcare transition skills and knowledge that people can handle by age. And we've discovered that the 12 to 14-year-old patients can actually understand the concept of adherence. But look at what happens to self-management. Only when you're about 20 years of age or more, you actually can self-manage your healthcare issues. That's way after they've left the pediatric practices. Now, what in our work and the work of others, what have we identified as barriers for healthcare transition readiness? We have, in collaboration with our Mexican group, Dr. Mara Medeiros, Cantú Quintanilla, and Ana Catalina Alvarez, we've described the same issues that we've described in the US. Low literacy is associated with less transition readiness. Having a lower socioeconomic status and having public insurance is also a barrier for healthcare transition readiness. Being a member of a minority group also is a barrier for healthcare transition readiness. In terms of being good citizen, those patients, those adolescents who don't do chores at home, are less prepared to transfer to the adult focused services and having an external locus of control, meaning the patients think that there are factors beyond their control that dominate their disease. Those are predictors of low healthcare transition readiness. What about caregiver barriers? Again, if you come from a poor family or have public insurance, that's a predictor of low healthcare transition readiness. If there's a single parent household or there's greater caregiver burden, those are barriers for healthcare transition. The same findings we've had in the US, our Chinese collaborators and our collaborators from South Korea have described that a non-cohesive family is also a barrier for healthcare transition. And again, having a great caregiving border on another cohort and a most recent cohort is also a program for healthcare transition readiness. Okay, so what is the role of the caregivers on healthcare transition preparation? We ask patients to tell us who do they prefer to learn about their health condition, and to our surprise, look at the answers. These were done in adolescents with multiple chronic conditions in partnership with Victory Junction Camp. And look at their favorite answer. The adolescents preferred to learn about their health condition from their parent, followed by provider, followed by the internet. That was a surprising finding to us because we had hypothesized that they would answer from the internet or from other patients like them. Pamphlets was the lowest. But the patients that answered the survey, they said to us that the internet is a platform that they go to play, and they don't like to go to the internet to learn about their disease, a disease they don't want to begin with. We've also described that if the patients prefer to learn from their parent, they're more adherent to treatment, whereas if they prefer to learn from the provider, they know more about their disease. And that's a problem because if they prefer to learn from their parent, we needed to know how much the parent knows about the patient's health. Based on our transition index and our parent-youth dyads, the parents don't score very much different from the kids. So that's a problem. And now we are focusing on teaching the parents and reteaching the parents about their child's condition so that we don't feel like the blind is leading the blind. We also have to deal with issues of low literacy. 40% of our patients are illiterate or have low literacy. We have a great number of single caregivers, and those are barriers for healthcare transition. We serve a diverse population with low insurance who travel a fair amount of distance to come see us. So we have to address for these barriers when we're preparing them or when we receive them in our practices. So in our publication that has been submitted for this blood purification for this particular Renal Research Institute meeting, we've discussed in great detail the why. Why is it important to have healthcare transition preparation? Important because it affects patient safety and patient outcomes. Where is the healthcare transition preparation? Where should it be done? It should be done both in the inpatient and the outpatient services. Because in the inpatient, there's a lot of downtime from the patients, and we could take advantage of that downtime, and we have a captive audience. Whereas in the outpatient service, we're more limited as to what interactions we can do with our patients. When should transition preparation start? Well, some of the manuscripts mention that age 12 is a good age to start. But many people don't have a lot of resources in their practices. So if you start at age 15, we have published at age 15 and greater, patients are a little bit more ready to be prepared to transition to adult-focused services. On the other hand, when should it stop? When does transition preparation stop? Or when do we transfer our patients? We transfer our patients when they achieve about 80% on their healthcare transition readiness tools, 80% score, 80% good answers. And when does it stop? It really continues in the adult-focused services, and it should continue until their mid-20s. So thank you, adult-focused providers, for continuing to educate our patients about their conditions. Who should do healthcare transition preparations? Everyone, all caregivers, all health providers or any discipline. And how it is best to have healthcare transition readiness tools to diagnose and measure the process of healthcare transition so that you know what areas the patients have mastered and what areas the patients have deficits on. We do this patient education using universal literacy rules. If we have a patient that comes with parents who are physicists, that doesn't mean they can read or understand medical language. So we use plain language and we use fourth grade material. For those of you who use NIH material for education, it's at about the sixth grade level. And sometimes for our patients, that seems to be too high even now. We have to adapt our patient preparation and our discussions to our patients' level of cognition and behavioral characteristics. Many of our patients, about 30 to 40% of them, have ADHD. So you have to give very brief interventions, very brief discussions when you're teaching them very important concepts, and you have to repeat and repeat and repeat again and repeat again. And for those of you who are in the adult-focused services, take advantage that the parents are involved, but help them delegate health management duties. We have Ana Catalina and I have discussed that adolescents and young adults with chronic or end-stage kidney disease have unique comorbidities and have great survival to adulthood. We have discussed that the adult-focused nephrology team needs to address the long-term impact of pediatric onset chronic or end-stage kidney disease. And we've also discussed that the healthcare is a process that involves the patient, the caregiver, and providers in both the pediatric and adult-focused services. I would like to stop by thanking our families, our patients, and volunteers for having or helping our program that is now 14 years old. Our mission is to teach, enhance, and promote self-management and transition readiness among 12 to 29-year-old patients. Our collaborators are across the country in the US and international collaborators, as you see their flags here. We have received past and present funding from the Renal Research Institute, the Centers for Disease Control, HRSA, NIH, and of course, from donations from our interdisciplinary team. Thank you so much for your attention.